Welcome to the Beverly Hills Plastic Surgery Podcast. I'm Dr. Jay Calvert, here today with my esteemed and astonishing colleague, Dr. Millicent Rovelo. How are you?
I'm good. How are you?
I'm good.
You
are astonishing.
I like astonishing.
I know, you are.
Better than being astonished.
Exactly.
I'll take it.
We have lots to talk about today, so we got to dive right into these breast implants.
Yes, today we are talking about breast implants and the variety of sizes and shapes and thickness and all sorts of implant type properties.
There are lots of options today with medical devices. When I was coming up as a lad before electricity, the implant choices were like A or B, and that was it. And you put them in, and they either look good or they didn't. And that was that.
When I'm bigger, you want them smaller. That's what you get.
You could get this size, that size, and it was over. But now we have different levels of cohesive gel. There's highly cohesive. There's like the gummy bears.
Yes.
There's all kinds of different properties to the gels. There's different properties in shape, sizes, the amount of fill of the shell. So let's get right into it. Tell me about your approach. You are a big time breast surgeon, correct?
Yeah, we'll go with that.
You are.
I'm into that. Yeah.
No, you definitely are, because I mean the amount of breast surgery that you do is frightening to me.
That is true. There is a lot of breast surgery.
It's like a
breast all day.
It is a snowball down a very large mountain of breast surgery for you. And you make it look great. So in terms of the implants that you use, you have so many different choices because you do breast reconstruction, you do breast augmentation for just people that just want beautiful breasts. You do augmastopexies, which is an augmentation with a lift, one of the more difficult operations in plastic surgery. And then you do revision breast surgery very frequently.
A lot. I do a lot of that. And so having a whole breadth of a breast implant kind of practice, I use a wide variety of implants. And I feel for my patients who come in and they are just overwhelmed by everything that they've seen on social media, the Google rabbit holes that they've gone down about different kinds of implants. And they come in and they're telling me, well, I would think I want a high profile, highly cohesive, gummy bear, moderate plus. And they're saying the words and they think they know what it means. And I get it because there's just so much information out there.
There's tons.
Really,
and it comes at you big
time. And it's really hard to just, distill the information into what it means. And number two, know which one is right for you. Like that's where being the plastic surgeon comes in. So let's talk about the implants themselves, and then let's talk about when we use each kind. So the implants themselves, there are three major implant companies. There's Mentor, Allergan, and Sientra. And whichever one your plastic surgeon uses, that's what they use. Not a big deal. Implant companies all have a little bit different tweaks, but
Can I just do a little Sunshine Act thing here?
Yes, do your Sunshine Act.
So we do not have any connection to these implant companies. We are not sponsored by them. We don't play favorites. We do choose certain companies.
Right.
I use breast implants from all three companies, depending on the situation, just to be very clear.
And I use mine from two of the companies. So
Ooh,
companies.
Really? Who'd you spurn? Tell me.
See, I'm not
Come on.
going to get into that. No.
Come on, dish. This is where you dish. You got to dish. What happened?
I
Not a good dinner at
Allergan.
one of these meetings, or
No, I use Allergan and
it's not good.
Sientra. So that's just what I kind of, use in my training.
there
It's
you go,
what I've
Mentor.
used.
There's your challenge. That's
Yeah.
the breast implant
Sorry.
challenge right there.
So
Sorry.
those are the three companies: Allergan, Sientra, and Mentor, and they all have sort of different implants, but more or less they're very similar. And so the implants themselves can be smooth or textured, and what that refers to is the coating of the outside of the implant. So bear in mind, we are talking about silicone implants here. There are saline implants that have a silicone outer shell, and they're filled on the inside with saline, with water.
That's a topic for a different day.
We're not talking about
which
that.
we will never talk about.
Because sure. Sorry.
I don't use saline implants. I'm sorry.
Yeah.
That went away with the end of the moratorium.
Topic for another day.
Yes.
Today, we're talking about the silicone implants,
Right
which
here.
are silicone on the outside, silicone shells, silicone on the inside. And so
Obviously different versions of the polymer.
different versions. And so when we're saying that we have smooth implants, like my purple fingers, I was marking
This
a
is
patient.
surgical marking pen,
This is
by the way.
surgical marking pen.
That's
I
the way it
was
works.
not wearing a glove. The outside is smooth. And the reason that's important is because textured devices do have an association with a very, very, very rare but very real cancer called ALCL. It's a type of lymphoma. This is a textured device, and you can see the difference. Dr. Calvert, if you'll hold this. This is a textured device. This is a smooth device. You can see that the texture has a kind of Velcro-y kind of texture.
Yeah, it's like speckled all over.
And it's designed that way because it's used for certain reasons to kind of stick and stay where you put it. That's a whole nother topic as well. But it's the textures that have been associated with the lymphoma. There was one brand, Allergan, that had all of their textured devices recalled. For that reason, I just don't use textureds. I don't think that there's a reason to use them. I use smooths and I use round. Round means that it is a round implant as opposed to being an anatomic or a shaped implant, which kind of has what they said was a natural shape to it, where it kind of had this like scoopy teardrop.
Natural alien?
They said it was natural, where there was less volume up top, more on the bottom. I hate those implants. I think they look ugly. Okay. I don't think they look like natural breasts.
They're awful.
They're awful. I take them out all the time. Let me
tell you a little story about that. I had one of the guys who was the guy for the anatomic implants comes to one of our societies, which will remain nameless, and gives like the paid sponsored lecture about using these anatomically shaped implants. And literally goes through probably 50 cases, through the hour while we're all eating our dinner, which was lovely. And at the end of it, I like wanted to raise my hand and say like, those aren't good looking breasts.
They're not.
Right?
They're not good looking breasts.
And I didn't say anything, but I'm like, do you not know what like good looking breasts are? Because those aren't it. Those look really freaky and strange.
They're weird. They're tall.
They're weird.
They have a funny shape. They don't look like they are marketed to look. And because they have a specific shape to them, they really have to stay in the position that they're put. And I have seen them flip upside down. So now they're in the wrong position. So theoretically, that's why they're textured, so that they do have that kind of Velcro stickiness and they don't flip around. And so that's the number 2 reason I don't use them. Number 1, I think they look ugly. Number 2, they are textured, and I just don't use textured.
I just don't enjoy the way they look. They just are not cute.
They're not cute.
And it is like, if you're going to have breast augmentation, you want them to look great. That's the whole point, isn't it?
Yeah. So we may have offended everyone out there that has anatomic implants.
And
our
boom.
apologies.
Sorry. Apologize. And maybe they are good looking on you, but they aren't. They just, I don't like them. That's just me.
It's not my style.
Not my style either. Okay.
So now here we are. So now we are down to smooth, round silicone implants. This is where it starts to get tricky, because you can have implants in all different kinds of profile. Let's start with the profiles. So a profile is how much that implant sticks off of the chest wall. Right. So you can have a low profile, which I have no representation for because I don't ever use low profile implants.
They look a lot like
they look like pancakes.
Smoking a pancake.
And so why would you pay for that?
Yeah, they are super flat.
Yeah. So yeah.
This is pretty flat. This is a moderate.
This is a moderate. So depending on the implant companies, they can be called a little bit different things. Allergan has low plus, moderate, high. Sientra has low, moderate plus, and high. So there's a range. But in general, this is going to be a moderate profile implant. Dr. Calvert, will you please hold that implant? This is
That's high profile.
High profile implant by the same company. So you can see how much higher that implant sticks off of the chest wall, if this is the chest wall here. And so that's going to change the sort of appearance or the augmented appearance of the breast. If you use a more moderate profile implant, that's going to give you a more natural shape with volume. So that's for the person that really doesn't want people to know that they've had an augmentation but still look really great and still have that upper pole volume, but not in a way that's particularly noticeable or enhanced. That being said, you can usually still tell that they're augmented. They're just not super augmented.
Right, and I find that moderate plus are also good with patients who have some breast tissue.
Yes, because if you put in a high profile in a patient that already has like C cup, D cup breast, they can get very large and very augmented looking.
Yeah, and just the over projection is a little bit funky.
Much.
Yeah, it's a little too much. But the moderate pluses do work well for people that have like B, C cup breasts. Yeah. Like, I just want a little more, upper pole, a little more, just,
Right.
I want it to be a little vavoom, you know, you
Yeah.
want to get that extra volume. A moderate plus implant
is
is
great.
great for that.
It's great for that. And then the high profile is going to give you that very full, enhanced look. No, that's not to be confused. People are like, oh, I don't want to look like I'm, super augmented. I don't want to be super obvious. I don't want them up to my chin. It's not going to be that because you have room to play with the sizes, and it does depend on your individual breast volume. But the high profile is definitely going to be a noticeably augmented breast, but it can still look, like we've said, naturally augmented. There can still be a softness to it. And I think they look really pretty. That's my style. I tend to use high profile in general, unless I have a patient that specifically says I want a more natural look.
Yeah, and I think the other part of that too is just, you don't want, nobody wants natural looking breasts.
I beg to differ. I had a case this week where that was the literally specific request.
Well, not if they're asking for breast implants.
This was a breast implant case.
They want it to look natural?
Yes.
I mean,
Yes.
The whole point is for them to look, really beautiful and full and gorgeous and all that stuff. So the way that I see that, and maybe your patient has a different idea of what it should look like, but they want the volume so that it looks, pretty in clothes, without clothes, whatever. Yeah. They want it to look nice, kind of at all times possible,
yes.
which by the way isn't always possible. Depending on the natural breast that we are working with.
True.
There are anatomic issues that we can overcome and some that we cannot.
Right. And that's usually for the patients that have really loose skin or have a lot of breast tissue at baseline. Those implants are never going to sit as high as we would like. There's always going to be some droppage, but they can definitely look better and get some more volume where you want it. So that's the profile. And the other thing that we do with the profiles is it allows us to sort of, I don't know, maybe how you play with it, but for someone that maybe has a smaller chest or a broader chest, I have room to kind of change how much volume I'm putting in for any given dimension. So if someone really wants that cleavage, but they have a broad chest, I can put in a moderate or a moderate plus implant because it's wider, but it still gives me volume. If I try to put in the same amount of volume in a high profile implant, it wouldn't meet in the middle. The base diameter here is it would be too small.
Yeah, I mean this is where, once again, and we say this with almost any operation we talk about, the battle is won or lost in the exam room at the consultation when you assess the chest wall, the breast base width, the quality of the breast tissue, and the full exam and analysis leads to the plan that is going to give you a great result.
Absolutely.
You have to make the right choice of device based on that consultation. It is not an on-the-fly choice in the operating room.
No, it definitely is not. And you need to know what it is the patient's looking for. Like the case that I referenced I had this week, I had seen her for a consult. We'd done a pre-op. I'd seen her a couple times. And she always said, I do want a more natural-looking breast. She had very deflated, A-cup breast, mostly skin. She needed an implant to get some volume, but she really did not want to have a lot of upper pole volume. She just wanted to kind of look like she did before she started breastfeeding. And I had an idea in my head of what I kind of thought that would look like and what would look really pretty for her. But then she showed me the photos of breasts that she really liked and that she wanted. And what she was showing me was actually natural B-cut breasts. She's like, this is what I want it to look like.
With no implants.
With no implants. So that's where it got a little tricky because I saw the look she wanted.
Yeah.
And so then my job on my end was to achieve that with an implant. So that's a whole nother.
You needed a magic wand is what you needed.
We made it work.
I'm sure you did. I mean, it is hard though. When you're putting in an implant, it's hard for it to look, quote unquote, natural.
Natural.
So let's talk about cohesivity.
Cohesivity.
Is it cohesivity?
Cohesivity.
Or cohesivity? What is it?
No, whatever you're saying is just no.
How about no, you crazy Dutch bastard? No?
No, that's not it.
Okay.
Cohesivity. So what that refers to is literally how cohesive the gel is on the inside of the implant. So cohesive is sort of just how sticky it is. And the actual scientific-ish explanation is how cross-linked is this silicone, how much is going on inside to keep the gel together.
Right, cohesivity.
You got it.
See?
Look at you. Yeah, old dog, new tricks.
I'm telling
what
you.
about that? So, little history lesson. back in the day, silicone implants, we're talking like in the 70s, 80s, early 90s, silicone implants were extremely runny, I think would be the best way of putting it.
They were called low bleed implants. That's what they called it.
Because they bled. So they would have a silicone shell, but the silicone on the inside was runny. It was like an egg yolk.
And it would make it to the outside.
And it would make it to the outside because the shells weren't as strong. They were more prone to breaking and rupture. And when those implants ruptured, that silicone gel would literally just bleed into the breast tissue, and it's a mess. We all have those patients that have had implants since the 80s, and they come in with ruptured implants, and you know it's going to be a mess in there because you get in there and you're just scooping out silicone from the breast for days, and it's sticky and it's gooey and it's everywhere, and it's a mess. It's just gross.
Guess what I'm doing on Friday?
An old ruptured implant.
Totally am.
Guess what Dr. Calvert's doing on
I
Friday?
am totally doing that exact case.
You want to be scooping
and you
out.
just made me go like, oh boy. I know it's coming.
Yeah, it's
the truth. We've all done it.
It's there. So those were old implants, and that's what kind of started giving silicone implants a bad rap, because this silicone would leak into the breast, then it would travel to the lymph nodes, and it would cause problems. Then there's a whole host of issues with silicone implants are pulled off the market for a while. More studies were done, and then they got reintroduced with FDA clearance. And the implants that came out after that ban are called like sort of newer generation silicone implants. This is probably like 2007-ish was when they came back on the market. And every silicone company has had newer generation of implants. I think we're at the 5th generation of implants now. But each one of them gets a little bit better in terms of how cohesive their gel is. So now the silicone gel that's in these implants, and regardless of the company, the gel is more cohesive, meaning that if you were to cut into that implant or if you were to have a ruptured implant, that gel is not going to bleed everywhere like it used to. It's going to sort of stay contained in one place. And the older implants, probably 2007 to 2012, a little less cohesive, but I think any implant placed after 2014 or so is probably going to have a fairly high cohesivity.
Now, do you have something you want to show us?
I do.
I know you want to do that.
I do. I have a show and tell. Before we get to that, I want to explain one more thing.
Go. I'm here.
You're
on a roll.
I know you're excited about my show and tell.
I'm standing back. I'm very excited about it. The show and tell is going to be pretty exciting.
So the implant companies have varying degrees of cohesivity. And it can be from their lowest end for the Allergan implants. That's sort of called their responsive line. Those are still considered cohesive implants, but they're less cross-linked. They're a little softer. And then they have a soft touch, which is their mid-range. And then they have their actual implant that they call cohesive. That's their cohesive brand. And that is a very not hard, but cohesive structure, but it definitely feels firmer than the responsive or the soft touch. And I really only use those in my reconstruction patients that just need a little bit more oomph to their reconstruction because they don't have anything. But those are heavy implants. Even in the reconstruction patients, I'm kind of moving away from them because they're just too heavy. The soft touch is a nice mid-range that I use pretty much across the board if I'm using an Allergan implant. Sientra has a similar set. They don't call it the same names, but they have different ranges. They have the HSC and the HSC Plus, the HSC Plus being a little more cohesive than the HSC. And that's sort of just dealer's choice with surgeon preference in terms of what they use. Now, Mentor is different. So Mentor doesn't go by levels of cohesivity. They don't really cross-link their gels. What they do is they overfill their implants so that they can get a similar aesthetic appearance in terms of having less rippling, but they don't have the same level of cohesivity that the Allergan and Sientra implants do. They're just sort of like coming at the problem from a different angle. So Mentor's solution to the cohesive problem is to overfill their implants.
This is an overfilled implant.
These are both Mentor implants. This one's obviously a lot older, and as you can see, it's soft and it's less projected as opposed to this one, which is clearly firmer and has much more projection and much less rippling. Rippling are these sort of dimples and bulges in the implants.
You can see it too when you kind of hang
it up like that.
Yeah.
So that's Mentor's way of coming at the cohesive issue. And people always come in and say, well, I want to get gummy bear implants. My friend has gummy bears. I heard about gummy bears. I want gummy bear implants.
And they just sound delicious.
I think because people just want to say they have gummy bear implants.
They love gummy
why
bears.
would you not want to have gummy bear breasts? Like, that sounds really fun. What gummy bear refers to is the name brand Allergan. Allergan trademarked the term gummy bear implant, and it refers specifically to that super high cohesive implant. And that's really the only thing it refers to. The implants that I was saying are kind of heavy that I don't use too much outside of reconstruction. That is technically what the gummy bear implant is. But now the term gummy bear has just come to mean really any implant that's of a newer generation that has that more cohesive gel structure to it.
But you know what they feel like to me? When I was a kid, we had a toy called Stretch Armstrong. And my brother and I you'd grab one arm. Each guy would grab one arm, and you'd pull it as hard as you could. And you would just stretch it out as far as you could, no matter how you couldn't break this thing. But it was very rubbery and firm. But it was soft enough that you could stretch it, right?
Right.
I find that the gummy bear implants feel like Stretch Armstrong.
Very, very much so. Not inside of you. Not like the patients aren't going to feel like they're a Stretch Armstrong. But
they are. They're like rubbery, and I'm not,
But if you play with them outside of the breast like this, yes, there's a little Stretch Armstrong.
Yeah, it's a
feel
little
to
weird,
it.
and that's the thing. Once they go in the body, when they heat up, I think, and they get the room to body temperature, then I think they do.
They do loosen,
They
soften.
loosen out. They get softened.
Yeah.
They flip, which I have. I have patients
A
that
lot. Those
Dang.
flipping implants.
I was going to say the flipping implant. But you can substitute your other F word in there if you'd like to. The flipping implants flip.
Yeah.
And the front goes against the chest wall.
Right.
And then the back side, which is flat, because it is like Stretch Armstrong, and now it's a deformity.
Right. So if
I
you
don't
think,
like
so
that.
this is how an implant is supposed to sit in the breast, right? Where you have a domed surface. But if you turn it upside down, now it's flat. And so
This is on the outside now instead of
than
this.
So this is a problem with heavier implants,
It is.
which is another reason I'm moving more away from the cohesives, even in my recon patients, because yes, I have problems with them flipping.
They flip.
And certainly, even in the lower cohesivity implant range, the larger the implant, the higher chance there's of it flipping. And it's a gravity thing. The larger the implant, the higher gravity works on it. They bend over, they move around, and it flips. And it's a problem, especially in larger breasted patients in general. They just seem to have a higher chance of things flipping.
Can you flip them back? Have you been able to do that?
On an occasion, and I would say maybe 1 out of every 20 times, I might be able to get it to flip back by manipulating it in the office. The thing is, sometimes they flip again, or I can't unflip them in the office, and then it's a trip back to the OR.
Yeah,
And
that's
so
what I have right now. I've got
it's a
one
pain.
like that.
Yeah, it's a pain.
I don't know what to tell her except,
Either live
gotta
with
go to
it,
the OR.
or
Yeah, live with it, or we got to fix it.
or fix it in the
drives me
OR.
nuts that thing flipped.
Yeah. So let's do our little science experiment.
All right.
All right, doctor, I'm going to hand this to you.
All right, let's go.
Will you explain what I'm doing, please?
Well, I'll hold it while you can explain. I'll be your mic holder.
So, we have here a highly cohesive gummy bear, if you will, implant, and we're going to see what happens when we cut into it. So say for some reason you have a gummy bear implant and it ruptures. Maybe there's trauma to the breast or something happens, and you now have a crack in the shell of your implant. This is what it's going to look like.
Or let's say somebody takes a
Or
scalpel
someone takes a scalpel to your implant. That sounds
That sounds very, very rough.
all right.
Like a rough night in downtown LA. There it is.
There it is, folks. So we're coming apart here.
Yeah, but you can see there's absolutely no bleed whatsoever.
Yeah,
It is just like
It's Stretch Armstrong.
it is. It looks like a rubber implant. It's very different. And that's back in the day. If you did that, it would bleed. It would run.
Egg yolk city.
Yeah.
So it's like over easy compared to like over, what is it? Firm, over medium, over.
Yeah. So let's see.
What's the fall end of?
Over
egg?
easy.
Over easy and then over.
Over hard.
Over hard.
Yeah.
Yeah. So over easy versus over hard. So this is a cohesive gummy bear implant. I mean, you can see why they call it gummy bear, right? Because it's like the inside of a gummy bear. And your implant would never, ever break like this in your body. At most, you may have a little crack in the shell. So this just doesn't go anywhere. Even if I push it, even if I mash on
it
doesn't go anywhere. So it just stays contained in its little shell. So this is what would happen to just about any implant on the market today. That being said,
very, very convincing, because it is. I mean, like, and we'll do a little video for that, for the gram and all that, with our with this little demo that we did, because it really is a unique characteristic of these implants. Because people are like, what if they rupture? I was like, they rupture, they stay right where they are.
Right.
They don't run anywhere.
Go anywhere. Yeah. Now that being said, so the implants, I think almost every implant company out there right now has 20-year warranties against rupture. That's how long the implant companies believe these implants should last for before they're even concerned about them possibly rupturing. So back in the day, the FDA recommended that, well, not the FDA, but it was a recommendation that you get your implants swapped out every 10 years.
Yes.
Because at 10 years, these older implants were at a higher risk of rupture. And like we talked about, when they rupture, it was a big, giant mess. So the thought was swap them out before they start to rupture. And so that idea has permeated, and I get patients coming in all the time saying, well, I'm at 11 years, so I need to swap out my implants. Probably not. Not if they were put in, and you're doing fine.
It ain't broke, don't fix it.
They ain't broke, don't fix it, because like I said, if they're put in after 14, 15, 16, they do have these 20-year warranties. So you have a good 20 years on them. And so coming back to what the FDA recommends, they have outdated recommendations that say implants should be imaged 5 years after placement, and then every 3 years thereafter to assess for rupture. And you can do that with an MRI or an ultrasound. But these have 20-year warranties against rupture. And even if they do rupture, say you have an aberrant implant that ruptures, it's not going anywhere. You could live with a ruptured implant of a newer generation for years, and it would not cause you any problems, because that silicone is not going to go anywhere.
No, and many people with the older generations of implants have lived with them ruptured for years on end, and it's not an issue because they're contained within the capsule, the tissue that forms normally around these implants.
Except one good reason to know if you have a ruptured implant, this might be an argument for some screening, is that if you have a ruptured implant and you go in for your mammogram, you can take that silicone gel that is contained within the capsule, and the force of the mammogram can push that outside of the capsule into the breast tissue.
That is true.
And I have definitely seen that. Mammograms are safe with implants. Mammograms can be done with implants. Breast cancer imaging is not affected with implants. But older generations, I do think mammograms have ruptured them. And I think if it is already ruptured, mammograms have forced the gel outside of the capsule into the breast tissue. Not so much an issue with current implants, but certainly I see it with the older ones.
I think you're right. I mean, I agree with you on that. The mammograms are, they're rough. They got to do the Eklund views. There's ways to do it that they should not damage the implants, but the reality is they want to see the breast tissue and check for cancer, so they're going to get the views that they want.
Absolutely, yeah. And generally, the people do fine, but that is something to take note of.
All right, we got through all the implants. We understand the cohesivity. What's your favorite implant?
I like the Sientra HSC Plus implant. So that's a Sientra implant. HSC Plus is their higher cohesivity, but not on the order of a gummy bear type implant. And the Sientra implants, and I don't have my own anecdotal proof yet or evidence that this is true, but they are marketed to say that they were more resistant to flipping than some of the Allergan ones, because the Allergan implants are flat on the back, the Sientra ones are a little more round. So I don't know. Maybe that's just marketing on their part. I can't say whether that's true or not, but I like them for how they feel. I like using them. I think they're good implants. The problem with the Sientras is that they have a more limited range of sizes. So sometimes if I have patients who need a specific implant in a larger range, I have to use the Allergan. I tend to use the Allergan more for reconstruction than the Sientra, again, because of the range issues. So I use different implants for different things. But in my cosmetic practice, I tend to use Sientra. I tend to steer more towards Allergan in my reconstructive practice. How about you, doctor?
I also love the HSC Sientras. They're really nice.
Yeah.
I like
HSC
those.
Plus.
The Plus. Yeah, that's what we have on our consignment here. Which
We have a wall of Sientra consignment.
We should get a little photo in front of that wall, actually. That's a great wall of silicone.
That is good.
Because I say that. I say, we have a wall of silicone. And they're like, what does that mean? I'm like,
come see.
You got to see this. It is cool. But I also there are certain cases that I like the Allergan soft touch. There are certain cases I like the Mentor extra filled high profiles. So I go, I'm sort of like, what do I think is going to be the best implant for this case?
Right, which brings us back to the very first question that you asked me at the start of this podcast. How do you choose an implant for your patient? Well, I look at every single variable we just talked about and what that patient needs. And that kind of flow chart is kind of what we went to school for. I could try it and explain every single thing that I'm thinking of, but it would take a whole year, because those are the nuances of what we do.
Yep.
So that's why it gets a little tricky when a patient comes and tells you the implant that they need, because it's like, well, that might not be what might be best.
I'm going to refer you to the You Don't Know podcast on that one, because we don't need to go through that again.
You don't need to go through it. But again, conversation is really important. Communication is key. Photos of what you like and or don't like are very, very, very helpful in terms of communicating your wishes. And then as a team, as a partnership, we can come up with the best implant for you.
Correct. But we do know, believe it or not, we know a lot about choosing the implant for the case.
We do.
Believe it or not.
We kind of know a little bit.
We have done, between the two of us, think about how many breast implants have gone through this practice. It's a ton.
It's a lot.
And that's the thing, is that there's a lot of experience that goes into those choices. And it's not just, I want, these because I saw them that so-and-so has them.
Yeah, it doesn't work that way.
It doesn't work that way because you don't have those breasts. You have your breasts, and you have your tissue characteristics and your desires of what you want it to look like. And we know how to get there. We're the pilot. We know how to fly the plane to get to the next place that we want to go. It can't be that you're like, and I swear to God, there was this one surgeon in New York when I was at Cornell. He threw in the towel on it, and he just said, I just let the girls tell me what they want, and that's what I put in.
And then it's on them.
And you put it on them like it's their, when they're not happy, it's their fault.
You chose that.
But I think that's BS.
That's not cool.
That's not how you do that, because of course it's going to suck.
Yeah, because
they don't know.
They don't know.
They don't know. Please listen to that podcast, and you'll understand why we say that. It's not that we're not trying to be like,
jerks.
jagoffs about it, to use a Pittsburgh term. Working at Jags and at, but you want to understand that your surgeon really does understand. Look at the before and afters. If you like the before and afters, then when we say this is how we can get there, then go, that sounds great.
Sounds good.
Ask your questions. What about this? What about that? That's fine. But directing traffic with surgery is really an issue, and this is such a artistic, touchy-feely kind of choice.
Literally touchy-feely. You got to touch and feel the breast.
The implants. You got to feel you got to understand the quality of the breast. There's so much that goes into making this awesome, and that's why your results. And I want to I don't want to blow my own horn, but I like my results. That's why I do it that way. Yeah. It's not. I'm not putting up.
I think your results are great. I love your results.
Yeah. Well, thank you. But shake and bake there. Then that's a. But the reality is that we want it to be awesome. We do, and we want to use our knowledge base. We want to use our armamentarium of devices. And you have to understand that it's surgery. There are risks with surgery. You can't just go into this blindly. You have to understand that there could be capsular contractures, all the complications that we've talked about on the complications podcast too. And I really do think that that's why this was such an important podcast for us to do, is to understand that it's not simple, and there is a discussion that needs to happen. And, doing your research is 10% of what you need to do. And then you have to come and get the exam, listen to the options that are there, and then make choices together.
Make your choice. And not to make it even more confusing for the patients, but if you were to go to 4 different plastic surgeons, you'd probably get 4 different answers in terms of what they thought would work best for you.
100%.
And that's not to mean that any of those choices are wrong.
Right.
Because those are the right choices for that surgeon based on what they like, what their aesthetic goals are, and how they like to make their breasts, and what they're comfortable using and what they are used to. So it doesn't mean that one is wrong and one is right. And that is what you were saying. It goes back to find a surgeon whose befores and afters you like, who you can trust on an interpersonal level, that you communicate well with, and then sort of trust, and then sort of let it go. Like, tell them what you want, show them the photos you like, and then you kind of got to trust a little bit there.
You do, because you know that the results are very much surgeon dependent.
Totally.
It is picking an artist,
It totally is. And the breasts that I like to make are totally different than the breasts that the surgeon down the street likes to make, than the surgeon in New York likes to make.
Yeah.
We all have our idea of what we like. It's just our preference. Not to say we can't change. My patient this week who wanted really natural breasts, totally made it happen for her. But we in general have breasts that we make a certain way.
Definitely.
And if that's a look that you like, then go to that surgeon.
100%. That is how to pick. And you know, obviously somebody that does a fair amount of this stuff, before and afters. I say it all the time. We say it all the time. It is a huge, way. It's like you want to pick the artist that's going to make you what you want.
Yeah, I think that's pretty much it. I hope that was helpful. I think it was a lot.
You crushed this podcast
in a short amount of time.
You did. You just you were all over it.
Like I did with that implant. I just cut it and crushed it.
You did. You nailed this one. It was good.
All right. Well, in that case, this is the Beverly Hills Plastic Surgery Podcast coming to you from the 90210.
So we're going to do our breast implants.
Breast implants.
Have we started the podcast yet?
No.
All right, we're starting now.
Have you said welcome yet?
No, I haven't.
No, sir.
Welcome to the Beverly Hills Plastic Surgery Podcast.